Here now. Everybody smile. Everybody smile. And welcome to Meet the Midwives. Sherry, can you see me? Sorry, we're having a little technical difficulty.
Yes, all set. You were hiding under Kate Murphy's name, and I was like, I don't see you anywhere. No, we're all set. Here we go.
All right, great. Thanks to the technologs that have helped me, because I'm not a good technology person. But anyway, well, welcome everybody to Meet the Midwives. We're so happy to have you join us here tonight. I'm just going to go through a quick overview of what to expect from us. The program will last about 1 hour. We're going to see a short video. We're going to introduce ourselves, and we're going to answer 4 of the most frequently asked questions. We'll go over statistics, and then we'll open it up to your questions. We'd love to answer any questions that you have. And one of the things that I'll ask you to do is to please put your questions in the Q&A and not the chat. And so without further ado, we'll start.
Midwifery.
Midwifery.
Is that right? Midwifery?
I don't know.
Midwifery.
Midwifery, yes.
Is that like a female in her 30s, like, I don't know, married woman?
I know they help during the birth of a child, but that's pretty much all that I know about it.
A midwife can also, as I know, like provide some pain relief in terms of like breathing exercises and things like that.
I think midwives work at a hospital.
Some are in hospitals, some are at home.
I don't think they work in a hospital.
Midwives are everywhere. We're in the home, offices, giving prenatal care, giving family planning care. We work in hospitals, we work in birth centers.
Most people, when you think of a midwife, you just think of somebody who helps women have babies. But we do a lot more than that. We work with women throughout their life cycle.
When someone comes to see a midwife, they often wonder about what we can do for them as far as pain management, as far as medications. They're worried that if you're with a midwife, you can't have an epidural, for example, which is not true. I think a lot of people are surprised to hear the level of training and education that is required to be a midwife in the U.S. because midwives do so much more than just birth.
We provide personalized care.
The main reason I chose a midwife is because I wasn't a number. I was actually a patient, I was actually a person with feelings, and they were gonna devote the time that I needed to answer all of my questions, address my concerns. They want you to make, good choices for you and your unborn baby. I'm so glad that I chose a midwife. It's definitely an ongoing relationship.
Midwives have reduced the cesarean section rate in this country. It's overall been drifting up in the range of 30%. The midwife practice here at GW has a cesarean section delivery rate of 5%. Physicians plus midwives is a way of putting together the collaboration that responds to what the patients want. Doctors should advocate for the midwives. I enjoy the sharing, I enjoy the collaboration.
I chose a midwife because they are trained to deal with birth as a normal process, not a medical emergency. I plan to use a midwife for the rest of my life for my healthcare needs. I trust them and know that they have my best interests in mind, and that's really important to me.
As midwives, our philosophy of care is based on respect for women.
We put the woman and her family at the center of the care and then build out from that.
We collaborate together. We're partners.
I think all women deserve a midwife.
Every woman deserves high quality, evidence-based, personalized care, and we're here to make it happen.
All right. Well, we're gonna kick off our more active part of the program with introductions. Erica, would you mind starting for us?
Hi, my name's Erica. My pronouns are she, hers, and I work in the Wellesley and the Dedham office. And so we like to say a fun fact, and my fun fact is that I love camping and hiking and exploring national parks. So my partner and I, for spring break next week, are going to Shenandoah National Park in Virginia. It's going to be a little road trip. Currently on the floor next to me is all my camping gear that I'm starting to get settled for the trip next week. So that's me.
Great, thanks so much. Caitlin, where's Caitlin?
I'm right here. My name's Caitlin Mayhew. My pronouns are she, her, hers, and I am out of the West Roxbury office. And my fun fact is that in midwifery school, I was living in Portland, Maine, and it became a really special place in my heart. And so I'm really excited to be going back to Maine this year, up in the mid-coast, north of Portland, for a week and do some kayaking and hiking up there.
Great. Where's Courtney?
I am here. My name is Courtney Enser. I use she, her pronouns. I am seeing patients mostly at the office and occasionally at Post Office Square. And my fun fact is that I still have a baby tooth, holding on strong.
Wow. Linda Rice.
Hi, I'm Linda Rice. I see patients at the Wellesley office and in Newton Wellesley. My fun fact, I've used this before, I'm a huge Broadway musical fanatic, but specifically I passed the gene along to my daughter, and we just came this weekend from New York. Her Christmas present was we saw Sweeney Todd in New York with Josh Groban. It was fantastic. So I will sing you Broadway musicals in labor if you like.
Deb, you're next.
Hi, my name is Deb Fiedler. My I can't speak tonight. Pronouns she, her, hers. And I always struggle over a fun fact, and I have in the past talked about my monkey that I had rescued from being euthanized. She was a pig-tailed macaque. And as I was thinking about it today, when I was in Japan, up on a mountain, watching the sunrise and drinking hot sake out of a little wooden box, one of the snow macaques up in there jumped over and took my cup. So somehow I felt that monkey knew about my past. So,
Kate, your turn.
My name is Kate Murphy. I work in our Norwood office. I am a mom of 3 boys, and my fun fact is that we are all going on vacation on Wednesday morning with all of our extended family as well, which is a first, to a resort in the Caribbean, which will not involve any form of camping, working, anything. But I am super excited about it, and I can't wait to relax, actually.
Excellent. Mary Kay.
Hi, everyone. My name is Mary Gosney. My pronouns are she, her, and hers. I practice at the Norwood and Cambridge offices and at Newton Wellesley. My fun fact always revolves around my grandsons, 1, 3, and 5. And my new thing this year is I think we've explored every animal known to boys. Dinosaurs, snakes, cows, goats, you name it. I never thought I'd ever know so much about animals. So it's a lot of fun.
Job. Where's Gaitan?
Hi, I'm Gaitan Belacy. I am a midwife in the Norwood and West Roxbury office. Fun fact, 4 was a really hard year for me as a kid. I got a brother. I crashed my dad's car. If you want an extended story, I can give it to you at a point in time. But I was very rambunctious 4-year-old. I've calmed down after that, but yeah, 4 was tough.
A 14-year-old?
Oh, 4 years old. 4 years.
Oh no. All right, I might need to hear that story. Megan.
Hi, I'm Megan Zisk. I practice in our Wellesley office. And my fun fact, I'm really excited that the warmer weather is coming. I really love gardening. I have all my seeds sprouting right now and love hanging out in my backyard with my flock of chickens.
Excellent. I'm Carol Hong. My pronouns are she, her, and hers, and I work out of the Wellesley office as well as doing deliveries at Newton Wellesley. And my fun fact is that I am actively daily practicing dance moves and Harry Styles songs because I and my daughter, who's graduating from high school, are going to Amsterdam to see Harry Styles. I don't know any of his music, but I'm learning it. I'm learning. Okay, students. We're going to talk a little bit about students who we have 2 joining us. We're so lucky to have them with us tonight, and also in our practice with us while they complete their education. So I'd like to ask Olivia. Is Olivia Dumont here to introduce herself and talk a little bit about yourself?
Sure. Yeah. My name's Olivia Dumont. My pronouns are she, her, hers. And I am a 3rd-year midwifery student. I've been working with Atreus since January now. And I'm due to finish in the next few weeks. So I have just had the loveliest time working with this practice. And my fun fact is that I'm graduating on May 22nd and will be out in the world as a new midwife soon enough. And I'm just really grateful to have learned from such an amazing practice.
Great. Is Nikki here too?
Nikki's coming on call, Carol, so hopefully she'll pop in with Jess later.
Okay, great.
Okay.
Well, we're going to start the frequently asked question part of our question. Erica, the first question is for you, and it is, what's the difference between a midwife and an OB?
Great question, Carol. So the way I like to answer this question is to start by saying actually how we are the same. So we are both OBGYN providers. So as the video is saying, we do full spectrum healthcare. So we do everything from menses to menopause. And our specialty, the bread and butter of what we do, is pregnancy, birth, and postpartum. So we attend births. A lot of people ask like, oh, so you can actually catch a baby? Yes, we actually do deliveries. We catch babies. And no, the doctor does not have to be in the room. More to come on that. And also in the bucket of what's the same is that you have the same options for pain management. And a lot of people assume that if you have a midwife, you have to have an unmedicated birth, and that's absolutely not true. We support you in whatever your pain management choice is. So what makes us different, of course, is a difference in education. That's kind of the more obvious thing. So doctors go to medical school and then they have their residency and they're trained as surgeons. Whereas we come from a bachelor's of nursing background, and then we have a master's education to become OBGYN practicing basically in the nurse practitioner level. And so our training is mostly coming from a background of supporting natural physiologic birth. And so that's a buzz term that we use a lot, but for those of you who don't know that term, physiologic just means birth the way that nature intended it. So it's birth the way that your body had intended and already had the innate knowledge of how to do. So we basically come from a different philosophy of care where we see birth from this natural process, and we try to support that natural process as much as possible and intervene as little as needed. And we feel that midwifery is not just a science, it's also an art, and it's also activism. So we work really hard to make sure that you have agency and autonomy in your care. We want you to be an educated client. We want you to know that you are the expert of your own body. And so we work as a team with you to support that. And then we take the time to understand your life background, your home environment, We like to know about your culture, your emotional state, because we believe that birth is not just a physical event, it's a cultural, emotional, spiritual event. So we hope that you're seen and supported as a whole person. And we know that we're not just meeting one person at the end of this, we're meeting two. We're meeting you as a parent, and also your partner. And so we want to support everyone in that process.
Great, thank you so much. That was such a great and complete answer. Caitlin, can you answer the next question, which is, what is collaborative care? What does that mean? What does that look like in labor and also prenatally?
Sure. So to first start off prenatal care, so the way that our practice works is it's a group of midwives and physicians, and we all work very closely together. Standard for everyone is that everyone sees a midwife first. As Erica just explained, we look at you holistically. We love to educate. It's very well-rounded. So we see you first and do lots of education. And then usually you would then, for your second visit, see one of the physician colleagues, and they would again review your medical history and your pregnancy. And after that, most people then either go back and forth between the midwife and physician, or decide to do mainly with the physician or mainly with the midwife, depending on their preferences. And then when someone develops some medical condition in prenatal care that might make them a little bit higher risk, we start to work a little bit more collaboratively. And what that means is that if you had chosen to see mainly a midwife for your prenatal care, we would be consulting more with our physicians. You might see a physician for a couple of visits, at least once a trimester, to make sure that your medical care is being looked at by both the midwife and the physician. And then in labor, what it means to work collaboratively is that we always have a physician colleague in the hospital with us 24/7, regardless of whether you've chosen midwifery care or physician care. If you've chosen midwifery care, you would not see the physician unless there's an emergency or a need for a C-section, or if we needed to consult for a medical reason. You would only see us as your midwife, as your primary team. But the collaborative care is really important because we do have that colleague to run concerns by if there's a need, and then also collaborate if there's a question with your care and labor as well. So it works really nicely in the prenatal setting and the labor and delivery setting. But again, if you've chosen midwifery care, that's what you would get unless there was a medical concern for us to go to our physician colleagues.
Thank you so much. The third question is, who is going to be with me at my birth if I choose a midwife? And if Courtney could answer that question, that would be great.
Yeah, so who's going to be there for your birth? So that would be you, of course, the birthing person. And then your primary support person, which is your partner, whoever you choose to be your primary support, the midwife that is there with you, helping you through your labor, as well as your labor and delivery nurse. And then when it's time for the baby to be born, you will also a second nurse come in to help take care of your baby. You can also choose to have a second support person, and that can be a doula, it can be another member of your family, but you can have two support people, and they're your primary support person, and then a second one as well.
Great, thank you so much. I just want to make a reminder to the audience, if you have questions, if you have information that you want, please ask us in the Q&A. All right, Linda, the next question is for you, and that is, how is the midwife going to help me in labor?
Thanks. And Erica spoke to this a little bit. I get those questions as well, that, oh, if I have a midwife, that means I can't have an epidural or I can't have pain medicine. And the benefits of a certified nurse midwife is that we kind of marry everything. We have the art of midwifery and the support, but also have access to, you can have an epidural, there's IV medicine, there's nitrous oxide, which is the gas that you can breathe in. And we know lots of other tricks. There's you getting in the tub, getting in the shower. Sometimes you just need to change positions or get up and walk, or sometimes you need to rest. And so I think a big difference in having a midwife is that we have the opportunity to be there with you a lot more than our doctors. And just, I think, having a presence there, constantly kind of answering your questions, constantly saying, oh, I think this isn't working out. Let's try getting up. Let's try laying down. Let's try getting in the tub. Does a lot. Pain is obviously very physical, but there's an emotional aspect. And if you're nervous or you're scared, it can make coping with discomfort a lot harder. So we try to be with you as much as possible to say, gee, you're doing great. This is really normal and you're doing fantastic. Or, this is slower and maybe here are some options. And like Era said, you're a part of the team and we will tell you what we think and we'll lay out options for you if we think something should change. And we want you to feel heard and feel like you have control over your situation, because when you feel like things are done to you, it makes you, again, anxiety and makes you feel more uncomfortable. So we'll be always kind of monitoring you, helping you and making suggestions and also giving you feedback and reassuring you and making you the pilot. You're the main part of the team, and we want you to be heard. And so that's, I guess, the main thing. Our goal is that you understand your options and that you're emotionally and physically and everything taken care of.
Great, thank you so much, Linda. We're going to ask Deb to review our practice statistics.
Okay, I just want to say one quick thing before I start the stats. As I was listening to everybody's introductions, I realized I didn't say what office I work out of. And I think maybe that's because I don't work out of any office. I am a hospitalist, meaning that I work exclusively doing labor and delivery and postpartum rounds. And I also organize and calculate our statistics. So in 2022, we had more like 54% of all the women coming in to give birth with Atrius at Newton Wellesley Hospital. So we do the majority of the labor care. As Linda was talking about epidurals, 77% of the women we care for opt to have an epidural for pain management and labor. 25% of the women we care for, their labors were induced, and a lot for medical reasons, not just because we usually will induce someone if they are what we call post dates, but meaning beyond the due date. Most of those we wait till after 41 weeks. Very low episiotomy rate, 2%. That's been pretty consistent over the years. And a lot of experience that we all bring to the practice. So lots of years of combined midwifery care. For RHS patients in 2022, 12% had primary C-sections, and compared with the primary C-section rate in the United States in 2021, which was 22.4%. And if you have had a previous cesarean, many women want to strive for a vaginal birth the next time around. And we work very hard to, when it's appropriate for a woman to try for a vaginal birth, we are very supportive. And as you can see, of the women we care for who are striving to have a VBAC or vaginal birth after cesarean, 85% of those women do have a vaginal birth. And it's pretty good when you look at the national rate, which in 2021 was 14.2%. So we work really hard to have women achieve a VBAC when they are interested in doing that.
Great. Thank you so much, Deb. Kate Murphy, if you could answer the very first question here tonight, which is during which trimester or at what week or what point in the pregnancy would one decide to go with a midwifery versus an OB decision?
Thanks, Carol. Some of this is really a fluid, active conversation that you'll be having with your primary providers throughout your prenatal care. You know, some people come to their first visit and they know exactly what they want, and they know they may not be having their first baby, or they're very clear, and other people have never even heard of a midwife, and that's something that we expect. And we anticipate that throughout your prenatal care, this is something that we're going to be talking about. And sometimes, you know, depending upon how your pregnancy progresses, we may steer you one way or the other. We may say, I think this is going perfectly. You're a great candidate for a midwife. Or if you have some more complications or things that make us think you're maybe deserve the care of a physician, then we'll, we're going to have that conversation as well. There's no really set timeline, but as we approach, the third trimester, that's when we're usually talking more about labor and preparing for your baby and starting to talk about what your birth preferences are. So it is usually some point during the third trimester that it's your decision to make. It's a shared decision-making process, but it is your decision to make, and we'll support you and continue to provide prenatal care for you and postpartum care for you, regardless of your decision about who you feel is the best fit for you when you go to have your baby. The end all is that you have to decide by the time you come to the hospital, really. So we know who's there to greet you when you come in labor and delivery. But there's, third trimester is a kind of ballpark answer.
Great, thank you, Kate. Mary Kay, our fearless leader, if you could answer the question, if I'm a high-risk pregnancy, will my OB and my midwife be present?
Thanks, Carol. That's a great question. If you have a high-risk pregnancy, you're most likely already have a care team, a primary provider care team, either your midwife, OB, or nurse practitioner in the office. And those people that take care of you prenatally may see you in labor and delivery, but we all rotate through our call shifts. We practice out of 5 offices. So you will have, if you're high risk and are seeing both a doctor and midwifery team in the office, we will see you as a midwifery physician team in the hospital. Now, there's different levels of high risk, so I don't want to make a blanket statement, but sometimes you might be just a little high risk, or some women think they're high risk if they're 36 and they're over 35 and they've had a very healthy pregnancy. We do report in the morning as doctors and midwives, and in the evening every time we change shifts. So you might be a healthy 36-year-old in labor and not need anybody but a midwife, and the doctors know that you're there, and we're communicating throughout the day, throughout the shifts in terms of your care. I always say to my patients, I'd love to be there for all of you, but it's humanly impossible. All of us on this call, our soul and hearts are in midwifery, and we really want to support you, but it's kind of humanly impossible. So that's why we have care teams. Our docs and midwives are all on the same page. If you have a plan with your care team in the office, we will do our best to support your care with that plan when you come to the hospital.
Great, thank you so much. Gaitan, if you could answer the next question from the audience, which is it common for women to tear and require stitches?
Well, it is common for a first-time mom on average to have a second-degree tear their first time around, but you can have a range of tears. There is what we would call a skid mark. There is a first-degree tear. There's second degree, which is a little bit in your vaginal muscle. There's a third degree, which is a little bit past that, almost in, and then there's fourth degree, which is into your rectum. But what we try to do is, as you're pushing, some people prefer to be coached, some people don't, but we can try to guide, help you with your pushing in terms of what I like to say to my patients is, as the baby's head is crowning, to blow like you're blowing out a candle. And that kind of helps to slowly move the baby's head out so that as the baby's head is coming out, that it's slowly stretching and allow your body to kind of experience that and then hopefully not tear as badly. So that's what I would say about that. And usually after your first time, usually the tearing minimizes. And we also do warm compresses, we use lube, and that all of that. So that all of that helps with tearing. And I also recommend, and I know all of my colleagues would recommend, perineal massage you can do starting at about like 35 weeks. That helps to decrease the amount of tearing that you might experience. And so research shows that. And so I would recommend that to you if that is a concern of yours. It can happen, it does happen, but it's a beautiful thing, birth, and your bodies are so incredible that, we heal so naturally and come back together.
Great, thank you so much. Megan just stepped out for a minute, so I'm going to answer the next question, which is, why are the C-section rates reduced with midwives? This question has quite a lot of facets to it, but to highlight, I would say, to touch on something Erica mentioned in the very first frequently asked question is the support that you receive in pregnancy, not just the physical support, but the emotional support. And then when it comes to labor, that kind of support is also extended to you. We're patient. We know birth is generally not a fast process, although it can be depending on what number baby you're having. And labor progresses differently for every woman. Sometimes it's a straight line. Sometimes it's up. Sometimes it's down. Sometimes it goes faster. Sometimes it slows down. Your body gives there's a biofeedback system in your body that allows you to gradually acclimate to what your body is doing. And so that's one reason. The next reason I would say is that because we're patient, we always ask ourselves two questions when we're evaluating what's going on in labor. And those two questions are, is the mom okay? And is the baby okay? And if the answer to both of those questions are yes, then we can take our time. We can be patient. We can see how your labor unfolds. Midwives tend to be there with you the whole time that you're pushing, so we can evaluate contraction by contraction how the descent of the baby is coming, how are things going the way that we anticipate, and if they're not, or if they're going slower than we expect or not as we expect, we can change your position. We're experts in knowing how to support your body's normal physiologic state of labor. And part of that is because we're there with you. The other thing I think that midwives do so well starts antenatally. It starts with developing a trusting relationship with you. And labor is a time when, if you look at other mammals that are, walking or crawling planet Earth, they look for somewhere where it's quiet and dark and private and they feel safe. And so as midwives, we really try to recreate that, sort of safe space for you so your body can do what it knows how to do. People have been giving birth for, is 10 million or more years. Not much has changed in terms of the process of labor. What's changed is our attitude towards birth. So, we try really hard to support the natural process of birth, and it's huge. Support is huge. If you think about any big event in your life, what can make the difference between something that's great and something that's not is the amount of support and care and love that you receive in labor, not just from your midwife, but from the people around you. So I think that would be my answer. And if anybody else has anything else to contribute, I would love to, open the floor to you too. Okay, I guess not. Erica, your question is, we're back up to the top again. So your question is, how does a doula add value alongside the work that the midwives do in labor? And what are some of the ways that the midwives, I think I'm interpreting this question correctly, what are some of the ways that midwives see the doulas as being helpful? And also, what is the difference between a doula and a midwife?
Okay, so again, we'll start with like the differences between doulas and midwives. So doulas are not medically trained, so they do have a training process that they go through. There are some formal training that they can go through, and some just train as apprentices, and some are self-taught. But they're trained in the like physical and emotional arena of birth in a support person context. So basically, they're not going to be checking your cervix or listening to your baby or delivering the baby. But they can really help with what Carol was just talking about, of helping to provide that supportive environment. And doulas have also been shown to decrease your risk of C-section. So a midwife doula team theoretically would be the best way to reduce your risk of C-section, if that's something you're hoping to avoid. And so doulas can add so much value to birth. We are so lucky to have Sherry here helping us out today. And some of my just favorite, most beautiful births that I've had at Newton Wellesley have been right alongside Sherry. So we really see them as a part of the team. And so typically when you hire a doula, you have several meetings with them during your pregnancy. And then some doulas also provide postpartum support too. So we do view them as in the same way that we view a support person like your partner or your family member, because they already have a different way of knowing you than we do. So of course we're limited because of health insurance to 15 minutes with you in the office. But oftentimes you get to spend a little more time with your doula, and so they know you on a different level. And so we really respect and value their perspective of, you know, how you want to be supported in labor. And they're there as another layer of advocacy for you. And there are days when we're on call where we have 4 people in labor at once. And of course, we're human, so we can't be in 4 places at one time. And absolutely, we would be checking in on you more often than a doctor would. That's just because the doctors are really busy when they're on call, because they're covering the emergency room and are very high risk patients in pregnancy and postpartum in the hospital. And then they are also on call for GYN concerns that come into Newton Wellesley when they're on call. So we still would be checking in on you very frequently, more frequently than our other colleagues. But if we have 4 people who are in labor at one time, we are kind of going, you know, room to room to room. And that doesn't happen very often, but a doula does add a lot of value, especially in those situations, because then you have continuous support. Sorry for the lengthy answer, but we love doulas.
That's a great answer. We love that answer. Caitlin, the next question is for you, and it is, how much time will I get with my midwife in the labor process, not just to catch the baby, but are they periodically checking in? Is there time to discuss birth preferences ahead of time before labor?
Yes, absolutely. So this is going off of Erica's question really nicely. So when you arrive in the hospital, if you have chosen midwifery care, we would greet you in the triage side of the 5th floor. And we would usually check in on you at that time and see how you're feeling, how labor is going. Oftentimes we would do a cervical exam or just a general physical exam at that time as well. And that is one of the first times that we do start to talk to you about your options for pain management. And if you have a birth plan, it's a really great opportunity to talk with everyone. There's the nurse in the room at that time, and your support person and the midwife. So with everyone in the room, we all kind of get to hear your preferences and discuss with you if you have anything in particular that you want your team to know about. So that's sort of the first step. And then you would generally move down the hall to the labor floor. And at that time, we would meet you in the labor room and then be checking in with you. Again, either if you're, depending on the patient load, we try to be in the room with you as much as we can. So whether or not you have an epidural, we still try to be in the room with you, because there's lots of different position changes and comfort measures and just talking with you that we can do regardless of whether you are planning an unmedicated birth or if you have an epidural. So we try to provide that continuous labor support. It's really helpful and beneficial, as I'm repeating everyone saying, it's a general theme. It just really helps with labor outcomes, with your emotional health and mental health support. So we're checking in, and then yeah, of course, as I think Carol said too, once it's time to start pushing, we really try to be in the room with you for the entire time that you're pushing. It's really important for us to be able to provide that support for you, not only because it can allow us to assess how you are doing pushing and how your baby's doing, but just because, again, it provides that extra level of just comfort, support, having that person that you've gotten to know throughout the whole shift, someone who really knows how you're feeling, your energy levels. So as Erica has said, as much as we can, we try to be in the room with you. And so we would be continuously checking in on you and your preferences. And if you have concerns, I think it's briefly been touched upon, but the midwifery model is really big on shared decision making and evidence-based care. So if there's ever a time when a decision is needed, whether it's a medical intervention or if there's a concern that there's a C-section to be needed, we really try to discuss with you all of the pros and cons of that and get your partner, your doula, everyone's input and support, and make sure that all of your questions are answered and that you're fully informed before we proceed with said intervention. So I hope that answers the question.
Caitlin, can you say a little bit more about prenatally, how we talk to women about what their choices are in labor prenatally?
Yeah, so around 28 weeks, so starting in the third trimester, we give you our 28-week packet, which contains a birth plan. And that's sort of the starting point for us to allow patients to start to think about their birth preferences. Of course, many people have started to think about this prior to that, but for those who haven't, it's a great way for them to have a structured piece of paper that they can take home and do their own research and really start to think about the questions. And then we encourage everyone to bring the birth plan back with them to their prenatal visits so that we can review with them all of their questions. We can discuss pain management options prior to when they even arrive in the hospital so that they know all of the choices that they have available to them. And then answering questions about support people. So it is a continuous conversation throughout the prenatal care as well, checking in with us. Yeah, we also encourage you to check out the Newton Wellesley birth education classes or other birth education classes that you may know of, but that conversation is had usually prenatally as well, so that you're just have all this information from lots of different sources, and we can keep reviewing it with you throughout your pregnancy so that you feel really comfortable about all of the choices that you might have available to you once you arrive in the hospital.
Thank you for saying that about the childbirth education. I'm going to jump in here for a second. I hope that I can be useful to you in regards to questions about that. If anybody sends any Q&A through about childbirth education stuff, I can send the links also to the tour, the virtual tour. But Caitlin, that was a really good answer in regards to looking to childbirth ed to help with specifics around birth plan, preferences, and otherwise. Thanks for the shout out.
Great. Thanks so much to both of you, to Sherry and Caitlin. Linda, Courtney, the next question is for you, and it's such a great and important question, and it's what opportunities are there for the partner to be involved with the process, with the birth process? Can they wipe off the baby? Can they cut the cord? What are the most common ways that partners are involved with the birth?
Yeah, that is a really good question, because I feel like a lot of times partners come in and they're kind of like this, like they don't know what to do. But it's really, up to how, you're comfortable with your partner, how much you're comfortable with your partner being involved, and how much your partner is comfortable with being involved. I feel like it starts at home, before you even come to the hospital. We want you at home for as long as you can be there. And the person that's going to be there with you is your partner. Finding good position at home, helping you eat while you're in early labor and stay hydrated, different massages or counter pressure on your back. And then when you come to the hospital, they can continue those things while you're getting more and more uncomfortable. And then, while if you do happen to get an epidural, still making sure that you're hydrated, making sure that, you have energy for when you go to push the baby out. And, then when it comes time to actually delivering your baby, that's, some people, the partner's just there watching and that's fine. Others, I've had dads put gloves on and they have their hands on my hands and we're helping the baby come out. Dads can cut the cord or partners can cut the cord. And wiping off the baby is another one. Partners can do skin to skin with the baby after the baby's born if mom is, not feeling well or tired. But really it's you, if there's something else that you want to be involved in or your partner wants to be involved in, you can just ask. And most of the time we're going to say yes, because we want that support for you and we want to support you in what your wishes are for your birth process.
Great. Thanks so much, Courtney. Let's see. I think the next question is for Linda, and that is what does postpartum care look like with a midwife?
Sorry. Hi. So we have in our practice always a midwife who's on call for labor and delivery and for antenatal, but we always have a postpartum, what we call a rounder. So a midwife will see you, even if you're cared for by a physician, even if you have a C-section, unless you have particular risk factors like severe preeclampsia or some reason that we think the doctor should see you, the midwife will see you every day, check on your physical well-being. We'll do some education about what to expect when you go home. The great thing, Newton Wellesley has wonderful nurses and also has lactation that sees you every day. But we can also help. Maybe we have a few little tricks up our sleeve for breastfeeding help, all those kinds of things. So a midwife will see you. We'll also see you for your postpartum visits. And usually we like you to go back to the midwives that you saw during antenatal care as much as possible. And part of it is because I think it's good for someone who knows you to see how you're doing, and especially to assess for things like postpartum depression. It's really good to see someone for those visits, but we also feel like we want closure and we want to see you and know how everything went. Because as we talked about, we can't be there 24/7 for our patients. So we always want to follow up with them afterwards. But our first time moms usually get a 2-week and a 6-week visit in the office. If it's not your first baby, and everything went great and you're feeling fine, we'll talk to you about just doing a 6-week visit and leave you the option of the 2-week visit. Because some of our moms say, I have 2 other kids at home and it's too much trouble for me to do the 2-week visit. But at 6 weeks, we'll do a complete exam. We'll talk about exercising and caring for yourself afterwards, talk about contraception, and all those kinds of things. So, and then after that, you can see us for your Pap smears, for your GYN care, for contraception needs, for preconception for the next. There's lots of healthcare for birthing people and that we can provide outside just the pregnancy. So we hope to continue to see you.
Exactly. Thanks so much, Linda. Deb, if you could answer the question, what happens when there's multiple people birthing at the same time? And also what happens when there's a shift change? Oh, Deb, you're muted, so we can't hear you. We still can't hear you. We can see your lips moving, but we can't hear you.
I've clicked it a couple times and it didn't respond to me. Okay, so even though we can take care of more than one woman in labor, it doesn't happen that often that people are right. Sometimes they feel like they're neck to neck and coming close, but it's very, uncommon to have two people right at the same point giving birth at the same time. Being in a collaborative practice, we can involve our physician colleagues, and they could step in. And usually if they were to do that, it would be really decided who would be the person that would benefit from the physician or the midwife, depending on all the aspects of their pregnancy and labor experience. There are times during a call shift that there's a second midwife on, sometimes doing rounds, but other times as well. So we strive as much as possible to have a midwife who is also present to be there and take care of you in labor. So I wouldn't worry, because it does not really happen that often. And if it does happen, we will do our best to be present for your birth. So it's not something, again, since it doesn't happen that often, that I think you have to be nervous about.
Okay. And the little part there about if there's a shift change, what happens?
I'm sorry, I forgot to answer that.
That's okay.
As Mary said, we do have at the change of our shifts, we do a sign out where we talk about what's going on with everyone who is there. So there is an overlap. And what we do is try to make sure there's no really break in the continuity of care that we're providing. Because there's an overlap, we try to make the transition from one midwife to the next. Not only do we talk about you as a person and what's going on with your labor and what has gone on in your pregnancy. So we talk about that. And we try to have the oncoming midwife come and meet women in labor so that they have that, feel like the transition is smooth. And I just have to reassure you is that when we do have that change of shift, that you are going to be welcoming a midwife who's coming on fresh and will bring different energy. We are all united in our philosophy of care, but we are, as you can tell tonight, we're all different types of people. And it's sometimes good to bring that good energy into the room. So it's not like when we say shift change, it's not like, okay, one's out and the other one's in, that we try to make that transition as smooth as possible.
Great, thank you so much. And I think this is the last question. We'll see how much time we have left after this one. But Kate, somebody wants to know, they want to know about pushing positions. Can you talk a little bit about what different pushing positions somebody might employ during their second stage of labor?
Sure. So you may have different positions that not only are you pushing in, but also giving birth in. And that's generally quite different if you've chosen an epidural or if you have not. If you've not chosen an epidural, you may somewhat involuntarily be in whatever position is working for you at that time. We definitely support women who are unmedicated giving birth on hands and knees. Some women choose maybe standing. Some people are laying on their side. There is a birthing stool. There's, some people are on their backs, and they may have always said throughout their prenatal care that they don't want to give birth on their back, and that's what's comfortable at that time. So for unmedicated women, it's really whatever is working for you, and we are flexible and will support you in that for sure. For women who have an epidural, we change positions all the time. So not only when you're pushing, but even before that, we put you in a lot of positions. We have different balls that we use. The bed can do a lot of different positions. Most of the nurses on labor and delivery are very well versed in something called spinning babies, where they do lots of different positions. to kind of help encourage your baby to turn and to get into an optimal position and to come down into the pelvis to hopefully make that pushing phase as seamless as possible for you. So when you're pushing, if you do have an epidural, you are in the bed. That is something that has to happen. That's a safety rule that we have at the hospital, but you can certainly get in different positions. We frequently have women on their sides, depending on how you've responded to the epidural. And some women are more numb than others, or feel some more strength in their legs than others. Sometimes people can use the squatting bar, and we just kind of support you and help guide that in a safe way. And that is a really nice way to use gravity when you have an epidural as well. Same thing with birth. When you have an epidural, we frequently deliver babies on sides. Usually it's more on your side or some sort of position that's recumbent or laying down, just because it is physically easier when you do have that medication in the bed. But there are definitely a lot of positions that we use. So it's certainly, sometimes people think, am I stacked on my back if I choose an epidural? And that certainly isn't the case necessarily at all. So that is something that we support. That is something that the nurses are very familiar with there and are really good about helping us with as well.
Great, thank you so much. Mary Kay, the next question is for you, and it's what kind of postpartum emotional complications do we look for, and how do we look for them? Is there a postpartum anxiety screening in addition to a postpartum depression screening?
So thanks for that question, Carol. We actually will start your emotional care and support during the pregnancy, sometimes even before pregnancy if you've seen us for GYN care. And we really want to connect and know what your support system is. We do screening throughout the pregnancy, usually at the first visit and also around 28 weeks. And certainly after you've had your baby, we address any of your emotional needs, whether it be history of anxiety or depression or new symptoms that come up anytime during your care. Really before, during, and after pregnancy. We have many resources that we can tap into for you. Sometimes if patients aren't feeling well at 20 weeks, we would do a screen and really make sure that we're supporting you in your emotional stability throughout your pregnancy, because pregnancy is a very trying time for some women. There's a lot of physical, emotional changes, and we want to make sure we take care of the whole person, not just your physical needs, but also your emotional needs.
Exactly, thank you. And we actually ask you, how are you feeling? It's a big question. Some people will really feel a difference in postpartum as they do in antenatal. And as Erica pointed out, you're the expert of your body, so we ask you. Well, I think we're almost out of time here, but I really want to give Sherry McBurney, who is a doula, a childbirth educator. She makes clothes. She's a multi-talented one. She's going to talk with you a bit about some of the things that Newton Wellesley and she offer, particularly as it relates to labor and pregnancy. So.
Thank you. That is my fun fact, isn't it? Like, I like dyeing anything that's white and cotton and wants to be colorful. So that's my fun fact. Don't walk by me in white cotton or else you will walk out more colorful. I'm happy to have your attention for just a moment. I'm so excited to be alongside all of these amazing midwives. I'm so grateful for their trust and for their partnership as a doula and as a childbirth educator at Newton Wellesley. And so I welcome you to ask any questions, and I'll stay on the Q&A. I'm the one who's writing to you. You get a typed answer. But I'd like to invite you to the virtual tour, which is so helpful. And there's so much to know about where do I go in labor and what do I need to know and who's going to be there in my antenatal room and how does this process work, as well as all the childbirth classes. I am part of a large team of educators that are just outstanding and ready to help prepare you for a birth experience that you can be really proud of, and part of writing your birth plans and some of these other questions that came up. So I'm grateful for being a part of your preparation in any way that takes shape. So thank you for throwing me the floor there, Carol. I appreciate it.
You're so welcome. So last thing I'm going to say before we say goodnight is that if you had a question, or if you had a comment, you wanted to know something, we didn't have time to answer it, or something comes to you after we disconnect from our program tonight, please, 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 please ask us. You can email, you can make an appointment with us, you can email Mary Gosney, who's our leader. Get in touch with us any way that that is most convenient for you. We really want to answer your questions. You know, we see our job in taking care of you all is giving you the information that you need and supporting the decision that you make once you have the information you need. So please let us know if there's information that you need. We want to be as helpful as we can. So, all right, I think it's 8:01, so we're going to be respectful of everybody's time. Everyone have a great night. Thanks for coming.
I remember when you were little, holding you in my arms. And now I'm looking out the window, watching you play in the yard. How does the time go by so fast? Sometimes I wish I could go back and do it all again, you see, because you mean the world to me. I am the one who loved you from the start. You are the one forever in my heart. And no matter where you go or who you may become, one thing that will never change is I'll always be your mom. It's a wonder just watching you grow up, seeing the world through your eyes, and all the precious things you say and do.
Hey, you guys, I almost had a stroke when I couldn't get the links.
We still have people on 1 minute.
Oh, I
You did awesome. You did awesome.
I had all of these catastrophic ideas, like
2 minutes, 2 minutes. You
Hold
did
on,
awesome.
hold on, I'm working on it. You're good. Okay.
okay.